ERCP remains the procedure of choice to achieve drainage in biliary obstruction. However, successful ERCP mandates endoscopic retrograde access to the bile duct. ERCP may be difficult or impossible in patients with surgically altered anatomy or gastric outlet obstruction. The drainage options when the papilla is not accessible include percutaneous drainage and surgical drainage. EUS-guided puncture into the biliary tree allows anterograde cholangiography. This technique has facilitated biliary interventions in failed ERCP procedures. The two main reported methods include 1. A rendezvous procedure involving EUS puncture and transpapillary wire placement to facilitate ERCP access, and 2. EUS-guided transmural drainage using stents to create bilioenteric fistulas such as choledochoduodenostomy or hepaticogastrostomy. We describe a new method of EUS-guided anterograde biliary stent placement in patients with inaccessible anatomy. Anterograde stenting is a well-described technique using the percutaneous route. We recently encountered 2 cases of biliary obstruction in the setting of advanced malignancy with an accessible retrograde approach. EUS-guided anterograde biliary metal stent placement was performed. The first case involves a 79-year-old female with history of a right hepatectomy and a Roux-en-Y hepaticojejunostomy 4 months prior for cholangiocarcinoma. On routine follow-up, she was noted to have abnormal liver tests. This prompted a CT scan which showed multiple hypodense hepatic lesions consistent with metastases and a dilated biliary system to the level of the bilioenteric anastomosis was noted. She was referred for palliative metal stent placement. Retrograde endoscopic approach to the bilioenteric anastomosis was not successful. We then used a linear array echoendoscope to target the biliary tree transgastrically. A dilated duct was punctured with a 19-gauge EUS FNA needle. Contrast was injected. A cholangiogram was obtained revealing a dilated left biliary duct with no drainage across the hepaticojejunostomy. A 0.035-inch hydrophilic guide wire was passed through the FNA needle into the bile duct and was successfully negotiated through the stricture in the jejunal loop. A tapered ERCP cannula was then advanced over the wire and across the anastomosis. The wire was removed and contrast was then injected to identify the exact location of the stricture. Although we could not confirm whether the stricture was malignant or benign in nature, given the known liver metastases, we elected to place a metal stent for palliation. A stiff guide wire was placed across the stricture through the ERCP cannula and passage dilation to 6 French was performed. This is not shown. An uncovered metal biliary stent was then successfully advanced anterograde across the stricture. After deployment of the stent, there was an immediate drainage of the retained contrast. The patient felt well post-procedure and there was no procedural complications. The second case involves a 65-year-old jaundiced male with a known adenocarcinoma of the head of the pancreas. The tumor was locally advanced and inoperable by imaging. Tissue diagnosis had been obtained at a prior EUS FNA. ERCP was attempted, but the ampulla could not be reached due to a high-grade duodenal stricture from tumor compression. Initial attempts for biliary access through transhepatic puncture with a 19-gauge needle were not successful, as peripheral intrahepatic ducts were only minimally dilated. We then attempted access through transbulbar puncture into the common biliary duct. After successful EUS-guided puncture, contrast was injected. A cholangiogram revealed a dilated biliary system with a distal stricture. A hydrophilic guide wire was then passed through the FNA needle and manipulated with some difficulty through the stricture and into the distal duodenum under fluoroscopy. After advancing a 6 French passage dilator across the tract and exchanging to a stiff guide wire, a covered metal stent was placed in an anterograde manner across the stricture. The stent extends from the common bile duct into the duodenum. The patient had no procedure-related complication. In conclusion, EUS-guided anterograde metal stent placement for biliary decompression is feasible. This may be an attractive alternative to achieve biliary decompression in patients with inaccessible retrograde anatomy at time of unsuccessful ERCP.